I'm not wearing a bulletproof vest because usually I have a lot of people, but I am protected by vitamin C. I have a big molecule on my back. So in terms of disclosures, if I can move this thing forward or backwards, it's stuck. Can we make it move? Do I need to point at something?
Is the lady there?
Oh, there we go. So maybe it's important, we're going to talk about fairy tales. We need to define what a fairy tale is. I get most of my medical information from Wikipedia. So a fairy tale means any far-fetched story or tall tale. It's used especially when any story that not only isn't true, but couldn't possibly be true. And we're going to talk about a few fairy tales. And I don't know if any of you believe in the tooth fairy. I used to. It's a fantasy. So the first fairy tale we need to talk about is early goal-directed therapy in the treatment of severe sepsis and septic shock. And this is the study, and there are a few points that are worth mentioning. Firstly, 288 patients were randomized. As we'll see, the study only included 263, 25 mysteriously were excluded. The second thing is people forget, this wasn't early goal-directed versus any care. The standard or the control was highly protocolized. There was a protocol on the control group which people forget. The difference between the two arms was this little piece here at the bottom where you either gave blood or an inotrope. That's what the difference was due to. Okay, and what happened is after publication of the study, people are like lemmings. They hang on to something, they don't critically appraise it, and they follow it like lemmings. So it was clear to me when the paper was published, this did not make sense. There was just a bad smell about it. So there were two papers that followed or led us to the editor in the New England Journal. As you can see, I was in Pittsburgh with that. I did not believe the study for the reasons I outlined then and turned out to be true. What we need to know is Dr. Rivers actually applied for a patent on the device he was testing before he did the study. So that's called a severe conflict of interest. Secondly, as we said, he randomized 288 patients. He excluded 25. So when hospital statisticians, this is in the public domain. This was the front page of the Wall Street Journal in 2008, just so that we know I'm not making this up. This was on the front page of the Wall Street Journal for everyone in the world to see. Hospital statisticians who worked on it had concerns about the data and recalculated the results with all the patients, according to people familiar with events. When he did this, people say, the death gap was not statistically significant. He conveniently excluded 25 patients who did not achieve the results that he wanted. Dr. Nathanson at the SCCM in 2016 presented a very detailed dissection on the study. It's interesting, Society of Critical Care Medicine removed his talk a week after the meeting because they didn't like what he had to say. Basically, he looked at the data and he found in the standard arm appears to be treated differently than EGD patients and not according to a protocol. And we know from people who were there, people in the control arm were not treated by a protocol. Secondly, when the paper was first submitted, patients were treated with digoxin. Part of early goal-directed therapy was to give digoxin. The reviewers thought that was ridiculous, so when it was resubmitted to another journal, the digoxin treatment arm suddenly fell away. So that's what we have to say about early goal-directed therapy. This data was known in 2008. Remember that. This is the current, off their website, the Surviving Sepsis Campaign Guidelines, which I took 2 weeks ago. Guidelines and bundles. So this was the first paper, 2004, Surviving Sepsis Campaign Guidelines. You see all the authors proudly displayed there, endorsed by all of these people. And what was it based on? It was based on two things. The early goal-directed study by Rivers et al., there you see it, and activated protein C. So you would think this was an attempt by the society to be very altruistic and to improve the outcome of patients with sepsis on this planet. No. This was a brilliant marketing technique conceived, produced, funded, and propagated by Eli Lilly and Company. Eli Lilly and Company, here we go. This was published in the New England Journal of Medicine in 2006. This was in public domain. Eli Lilly and Company designed this this surviving sepsis campaign. It was their idea. They just bought the Society of Critical Care Medicine. And we see Lilly provided 90% of the funding for surviving sepsis, which has an enormous budget, was paid by Eli Lilly and Company. The remaining 10%, who was it paid by? Edwards. What did Edwards do? Edwards made the catheter to measure mixed venous O2. And what happened? This is, again, this is Lilly and Company, and this is a quote from Mitchell Levy: approval of Xigris breaks new grounds, and with the launch of Surviving Sepsis Campaign, Eli Lilly and Company's sales of activated protein C ginormously went up so they could make their millions of dollars. That was 2008. This is from Philip Dellinger's update in 2010, 2 years after that publication, in which he says he has no disclosures, but he still admits Eli Lilly and Company are sponsoring surviving sepsis. This was 2 years after it was known publicly that Eli Lilly and Company had ownership of surviving sepsis. So, 2010 now. This is a remarkable publication. So the title is The End of the Line for Surviving Sepsis Campaign, but Not Early Goal-Directed Therapy, written by Dr. Rivers. So based on the Surviving Sepsis Campaign data, he says attainment of a CVP of greater than 8 and mixed venous of greater than 70 did not influence survival in patients with septic shock. So the originator of this protocol now says actually it doesn't improve outcome, and yet it stays with Surviving Sepsis Campaign. So, like Rocky 1, bad story, bad actors, bad storyline, we have Rocky 2, Rocky 3, Rocky 4, Surviving Sepsis, 2008, 2012, 2016. Same actors, same storyline. Yet, then we come into 2014-15, where we have 3 randomized controlled trials showing early goal-directed therapy, as we all know, does not improve outcome. Indeed, more recent data shows that in the sickest patients, early goal-directed therapy actually harms patients, significantly increases mortality. And then we have Mervyn to thank. We know part of surviving sepsis to give antibiotics within 1 hour. This was a really nice editorial written by Mervyn. Incestuous amplification, the extreme reinforcement of ideas and beliefs that occurs when like-minded people communicate, I would say conspire with each other. Okay, that's from the horse's mouth. So if we look at surviving sepsis, we see all the pillars that support surviving sepsis have come crashing down. Mixed venous, central venous, hematocrit, early goal-directed. We'll talk about lactate on Saturday. These have all come crashing down. So that leads us to where we are now. Surviving Sepsis Campaign bundles 2017. This is 2 weeks ago off their website. So what do you have to do? Within 3 hours, you've got to measure lactate. And as I'll show you on Saturday, it's a myth. It's nonsense. We obtain blood cultures. Yeah, that's a good thing. Administer antibiotics within an hour. As we say, there's no data to support that, as Mervin's editorial really nicely states. And then we dumped the CVP, but in its place we put administer 30 moles per kilo of crystalloid for hypotension or lactate greater than 4. So you would imagine there's good data to support that. Actually, there's no data. There's absolutely not a single scrap of data to support this. And Kyle Inc. gave an outstanding lecture this morning where he actually showed that this approach impairs microcirculatory flow and organ perfusion. So, they tell us this, it's a strong recommendation. And a strong recommendation means you have to do it. You have no option. But remarkably, they say low quality of evidence, but in fact, there's no evidence. In fact, the evidence speaks to the contrary, as I'll quickly show you. What's more astonishing, and this is astonishing, what they're telling you to do is if your patient has acute respiratory failure or has pneumonia, what you need to do is intubate them before you give them the fluid that's going to be harmful. So you have a patient in respiratory failure, you intubate them, you put an endotracheal tube down their throat so you can give them fluid for which they're not going to benefit. And in fact, as I'll show you, that is mandated by the federal government in the United States. If you're in respiratory failure and you're septic, you will get 30 moles per kilo. So, I could present you hundreds of papers to show you that that's bogus. So this was a little silly study we did. We looked at 23,000 patients in the United States on day 1 sepsis. So we looked at fluid given. This is all the fluid they got in the emergency room, the fluids with all their IV bags. We use IV bags. All the fluids they got on day 1. And then what the fancy statisticians did is for every single patient, they developed a risk of death score. So they could then look at predicted versus actual death for every patient. And what you see is above 5 liters, the rate of death goes up significantly. If you get more than 5 liters on the first day, your risk goes up. But interestingly, if you give less than 5 liters, 1, 2, 3, or 4, your risk of death goes down. Your risk of death goes down. So this contradicts this notion that under resuscitation impairs organ perfusion and outcome. As we'll see, under resuscitation was statistically associated with a small benefit. So then we need to go to this study, okay? So people don't like this because it was done in Africa. Like, that's really insulting. So what did they do? They took patients who were sepsis, they randomized them to 2-liter bolus of fluid within an hour, and then another 2 liters or standard of care. This smells very much like early goal-directed therapy. And what did it do? It actually increased the risk of death. Although it was a small population, they showed a significant increase in death in patients who received aggressive fluid resuscitation. So, I thought to myself, you know, people don't like me. How much more unpopular can I possibly be? So what I did is I sent a survey to every single member of the surviving sepsis campaign. And I asked them, that's the question. This current surviving sepsis campaign recommends that in resuscitation of sepsis, you give 30 moles per kilo. Do you support or agree with this recommendation? The answer is yes or no. You either agree, you disagree. There's nothing in between. So, that was the survey. And I sent it to all the physicians, every single one of them on that list. Okay? I did it in an adaptive design, so I wouldn't have too much crap on my face. Anyway, here's the result. I got 40% response, which is not bad. Most of them were pissed with me. Anyway, the overwhelming majority voted no. 62% of the respondents on this committee, their own recommendation, do not even agree with their own recommendation. Isn't that remarkable? And if you use the 20% threshold, which they state in their guidelines, you have to reject this recommendation because over 20% of the people on that committee reject that recommendation. Is that not remarkable? So Manny did a little survey concurrently, and you can see the result is exactly the same. 61% of people surveyed in Fluid Academy, people that are going to be here today, reject this recommendation. So you can see what MCRIT said. That is exactly it. Let the clinician be a clinician. This mandating, forcing us to ignore our patient is, you can read what that is. Wake up. Most clinicians seem not to be following your commandments. So it's really interesting that we've been hijacked by a small group of medical whatever. So the answer is the dose that makes the poison. All things are poison. Nothing is without poison. The only dose permits something to be poisonous. So I contend to you that with fluids, you have to be really cautious, and this idea of flooding patients indiscriminately is harmful. So we briefly have to talk about the bundle.
Yeah, Paul, you've got a minute if you can.
A minute. So I'm going to talk about the bundle in a minute. So in 2004, when this whole shenanigan started, their goal at that time was to operationalize this. That's their, and what Mitchell Levy says, surely we recognize the need to give up some measure of autonomy, yield some decision-making power. The data certain suggests that when we surrender this autonomy and standardize care, patients do better. So what is a bundle? It's a structured way of improving the process of care, a small piece of set of evidence-based practices that when performed collectively and reliably have been proven to improve outcome. The bundle elements are well established, proven in scientific tests, and all based on RCTs and what we call level 1 evidence. So how much level 1 evidence is there for any other recommendations? The bundle must be followed for every patient, every time. There should be no controversy involved, no debate or discussion of the bundle elements. Addition of other strategies not found in the bundle is not recommended. For every patient, every time, no controversy, no debate, you will follow the bundle. And there we go. And that's what Andrew Rhodes had to say. The problem with this is you guys in Europe are free. In effective October 1, 2015, this is mandated federally by the federal government in the US. We, by law, have to follow these ridiculous recommendations. And who's on this committee? No one else but Dr. Rivers, Mitchell Levy, Philip Dellinger, and Sean Townsend. Thank you.